Good afternoon, everyone, and welcome to the Board of Pharmacy's webinar today. I'm Tom Glenski, Chief Inspector, and today I have Josh Moore. He's the Pharmacy Director at Mo HealthNet, and he's going to give us an update from Mo HealthNet. Before I turn it over to Josh, I'll just go through some of our introduction slides if you haven't been on one of our webinars before. On your toolbar, you're in listen only mode. If you have any trouble connecting through the computer, you do have an option on your toolbar to connect via a telephone, and it gives you instructions on that toolbar there on how to do that. This has been approved for 1 hour of Pharmacy CE. If you're not signed on individually to go to webinar, you do not get credit for CE. So you must sign in under your own login. At the end of the webinar, I'll go over instructions for how to obtain CE. And just a reminder, we do not submit CE credit to the CPE monitor, so it's important that you save your certificates. Handouts are posted on the board's websites up under the upcoming events tab. You need to scroll down. We actually have two webinars posted on that today, and scroll down to the second one and you'll see the handouts link there. Also on your webinar toolbar, you can find the handouts too if you want to see them there. We make a recording of our webinars, and they can be found on our web page with all the other ones, past webinars. And during the webinar, if you'd like to submit a question to Josh, you can use your toolbar, type in the question and hit send. Time permitting, we will try to answer some of the questions that come in during the webinar. So I'm now going to turn it over to Josh.
Hi everyone, I'm Josh Moore. I'm Director of Pharmacy at Mo HealthNet, and thank you for taking the time out of your very busy days today to listen to an update on Mo HealthNet, our policies, and a little bit about where we're going over the course of the next year. On the agenda today, we're going to do a brief COVID update. We're going to talk a little bit about how we do our automated prior authorization process. Diagnosis codes on pharmacy claims, which we put a bulletin about recently. That's coming up next month. What we're focusing on with benzodiazepines and other deadly combinations of medications, what we expect during psychotropic polypharmacy reviews, a new reimbursement for pharmacists for administering healthcare administered drugs, and then briefly third-party services for PA requests. And then at the very end, I've got a number of links available for all of our information should you need those. First, COVID update. As we posted in March, we are at 50% for our early refill. We're going to remain at 50% for now. We will send out a provider blast prior to changing back to the 85% that we were at prior to March 13th. Just as a reminder, that means on a 30-day prescription, we will allow a refill after 50% of the medication is utilized, and that's to allow patients to potentially stockpile if they need to quarantine or self-isolate. They could have up to 45 days on hand. Another topic that we notified pharmacies about back in May was copays and shared dispensing fees. Pharmacies are not allowed to charge copays, which are shared dispensing fees, for Mo HealthNet paid claims during the COVID-19 public health emergency. This was a change that Mo HealthNet was required to make in order for us to receive additional funding from the federal government. These copays, what I'm not talking about here is anything on the MoRx program, or when we are paying only 50% of the participants' copay. These are for claims that are going through for items like lisinopril that might have a 50-cent copay normally. Those copays should be waived or not charged at this time. Mo HealthNet does actually not report to the pharmacy what the copay should be for a given medication. Each pharmacy, through your switch vendor or your software vendor, is applying that extra copay to each claim individually. We've tried to reach out to all the various pharmacies and pharmacy systems and switch vendors to let them know to remove the copays for now. But as we've heard from the field, there is mixed results from that outreach. This goes along with, in general, if a participant tells a pharmacy that they cannot afford the medication that day, the copay should be waived, but is still a legal debt to be collected later. But during COVID-19, again, there are no copays on MoHealthNet paid claims. Next item, flu shots. As we go into the next flu season, I just wanted to do this update. Make sure you're reviewing the CDC guidance as far as PPE when giving flu shots. Right now, it's for both the patient and the provider to wear a face mask. The eye covering is recommended, and in general, where COVID activity is high. So please keep an eye on the CDC guidance in regard to flu shots. Next item is telehealth. DC Pro was already eligible for telehealth, and during the public health emergency, a telephone encounter is acceptable. All right, a little bit about the automated prior authorization process. As many of you all know, MoHealthNet has a wide variety of edits that we employ in order to save the state money and take good care of patients. These can be preferred drug lists, clinical edits, fiscal edits, and they can contain clinical criteria, dose checks, a myriad of factors that we do in a real-time basis. We also recently, in the last year and a half, have our rare disease advisory committee that reviews drugs that impact less than 200,000 people in the United States. As MoHealthNet develops criteria, we do not do this in a bubble. We actually work with our drug prior authorization committee and our DUR boards each quarter, and we review each edit on an annual basis. Both of those meetings are open to the public, and at the Drug Prior Authorization Committee, we actually invite public comment. So I invite everyone to join those meetings and listen to the edits. We post the agenda at least 7 days in advance, and we post the criteria usually 2 to 3 days in advance so that everyone has an opportunity to review any criteria changes that we're going to make and then provide input before we make those changes. Due to COVID, we've actually moved those to WebEx, and they're still open to the public. We have actually seen an increase in people joining those meetings, and we really appreciate the feedback. It helps us a lot with making decisions. I want to give you a little bit of idea about what the automated prior authorization system looks like. I know when I worked at retail pharmacy, it seemed like every single claim denied. I can tell you that that's not the case. We're going to look at fiscal year 2020 just to go over some statistics. During that time frame, MoHealthNet reimbursed pharmacies for approximately $1.4 billion worth of ingredient cost and dispensing fees. That's about 14% of the MoHealthNet budget. We have an automated prior authorization process to review claims transparently at the point of sale. We removed from these statistics the duplicate claims. I know when I worked in the retail world, if at first they did not succeed, I went ahead and pressed enter again to see if I could get that claim to go through. So we removed a lot of those duplicates. We reviewed 11.6 million point of sale claims by this solution. We initially denied 2.7 million claims at point of sale. 163,000 of those claims resulted in phone calls to the help desk. As you'll notice, there's quite the difference between the 2.7 million and the 163,000. That could be due to a number of factors. It could be a claim that ultimately went on to be adjusted so that it did meet the coverage criteria, or the prescriber changed to another medication, or just no further progress was made on that medication. So when those 163,000 claims go to the help desk, we actually only end up denying about 43,000 of those. So we do about 120,000 approvals in a year, so about 10,000 per month. Those denials that come to the help desk are about 0.37% of the total claims that end up getting submitted. But this results in an almost $200 million program savings for the pharmacy budget. All right, next month, we're going to be implementing a change to allow pharmacies to actually submit the diagnosis code on the pharmacy claim at the point of sale. This is actually part of the NCPDP transaction, so all of your software should be able to already handle inputting a diagnosis code whenever you submit the pharmacy claim. We'll actually be able to use that in our adjudication process. The diagnosis must come from the prescriber. You cannot assume that you know what the medication is being used for, and you cannot ask the patient. The diagnosis code, again, has to come from the prescriber. What does this mean for you? Why is this important? We, through reviewing our call center statistics, estimate that up to 30% of all of our calls are due to the initial claim not having a diagnosis code already on the patient's profile. What do I mean by that? Let's think about a Humira prescription. Typically on a Humira prescription, we would expect that to be for arthritis. There's a number of other things that could be indicated for it. If the patient walks out of their doctor's office today with their prescription for Humira, when they show up to the pharmacy to get that medication, it's very unlikely that the medical claim will beat them there. So you oftentimes will call the healthnet pharmacy help desk and say, the patient was diagnosed with RA today, and then we'll go ahead and put in the authorization and approve that claim. Now, you can put in the diagnosis code, the ICD-10 diagnosis code, into your point of sale system, and we will use that in the adjudication process in order to pay the claim without ever having to pick up the phone call and call our help desk. Again, this will be effective August 16th. We are currently putting the logic into place for all, I think, 100 edits that require a diagnosis code in some form or another, so that we can have most of this ready on August 16th to be processed. We are going to review what the trends look like in diagnosis code. What I mean by that is if a pharmacy decides to take it upon themselves and put in the same diagnosis code for all of their patients in order to work around the system, we will work to look to see if that code is actually legitimate or not, and we might have to have a discussion with that pharmacy. At this time, the diagnosis code is going to be optional. That might change in the future, but for right now, it is an optional service to reduce some of the phone call volume that you're having to make from your pharmacy. All right, the next topic, I think I've heard quite a bit of feedback from some of my pharmacy friends on benzodiazepines. We put in a benzodiazepine edit back in August of last year. I got the question of why. They're very, very cheap medications. This just causes a lot of stress and burden on the patients, the pharmacies, and the providers. As we looked at issues that we were seeing in healthnet participant profiles, we were noticing very, very troubling trends in benzodiazepine prescriptions. We were noticing super therapeutic doses that really had no indication that we could tell on their profile. It wasn't uncommon for us to see 10 to 12 milligrams of Xanax a day being requested and filled by pharmacies. We were seeing multiple benzodiazepines concurrently being prescribed and dispensed to patients. A few of our patients had as many as 5 benzodiazepines that they were taking at one time. Dangerous combinations. We're going to go to the next slide so we can actually visualize this one in a second. But benzodiazepines and opioids used together is a very troubling trend. So troubling, in fact, that there was federal legislation put in place called the Support Act. And one of those pieces in the Support Act is that we need to monitor and put in prospective reviews for the combination of benzodiazepines with opioids due to the risk of serious adverse events, including dizziness, lightheadedness, slow or difficulty breathing, coma, and possibly death, which is actually an FDA black box warning. We also noticed that a lot of our patients had no record of any trial of any other medication to treat their anxiety other than a benzodiazepine being long-term monotherapy. So no trial ever in the patient's profile for an SSRI, SNRI, buspirone, any of those products. When we looked at what our utilization data looked like, this is the graph that we noticed. So on the left-hand side is the axis for concurrent use of benzodiazepine and opioid, and also participants on a benzodiazepine. The right-hand axis is participants on opioids. So while the trend has been to decrease both concurrent use of benzo and opioid, and the number of participants on benzodiazepines alone, and the number of participants on opioids, there are still 50% of our patients that are on a benzodiazepine that are concurrently on an opioid. So in the next several months, we do plan on implementing an updated prospective edit to try and manage the initial starts of benzodiazepine and opioid therapy. We haven't finalized that protocol yet, but we will be sharing information with it as we move forward. The next item on our agenda is actually the psychotropic polypharmacy reviews. We get a lot of feedback from pharmacies and providers and patients on our psychotropic polypharmacy reviews. And so I want to take a little bit of time today to talk about what we're looking at when we're doing these polypharmacy reviews. It's incredibly hard to do these as a prospective edit because what we're looking for is multiple medications on a patient's profile, and it depends also on how the pharmacy is actually billing these, so in what order they're being filled. With patients that are 5 years and under, we do a review once we notice more than 3 medications on their profile, and then for those 6 and older, we'll do the review once they are on 5 or more medications. We do subtract out seizure medications if the patient has a seizure diagnosis on file. So we have a current list of what we consider to be a psychotropic medication on our website. What are we looking at? We're looking at multiple drugs to treat the same symptoms. We're looking for multiple drugs where one is treating the side effect of another. We're looking for scenarios where the prescribers don't know about each other or the pharmacies. We frequently get in profiles where a patient is on 2, 3, or 4 atypical antipsychotics, and they're coming from different prescribers, and then the patient's also on medications to treat those side effects. We do these reviews, and it might seem like we're being very, very difficult, but we're doing this because we want to make sure that these patients are receiving the best care, and everybody that's caring for the patient knows about all the medications that the patient's on. Typically, what we're going to be doing is we're going to be giving a 1-month approval on the medication the first time they call in, if the patient is established on it. This is being done so that we can give the prescriber an opportunity to actually answer the questions that we have regarding the therapy. For instance, a recent review that we looked at was looking to start a second atypical, but they hadn't maximized the dosage on the first atypical. So we asked if the prescriber was going to maximize the dose first, or if it had been considered. There might be reasons why you don't maximize the dose on the first atypical before starting the second one, but we at least want to ask the question. These reviews, while they are troublesome, have resulted in a dramatic decrease in the number of concurrent atypical antipsychotics that people are on, and the number of patients that are on multiple meds treating the side effects of others. What we would like to ask pharmacies to do is, as you're calling into the help desk and getting these one-time overrides, please still work with the prescriber in order to tell them that they definitely need to answer our questions, because all that will happen is it will result in delayed treatment to the patient if we don't get the answers on time. We actually recently reviewed another patient this week where we've been working for 6 months to try and get reasons back from the prescriber on why the patient was taking 6 different medicines. We got very, very nondescript answers. We also got answers that polypharmacy doesn't exist. And these are issues that we battle day in and day out. And we would appreciate the help and the continued support from pharmacies in order to push forward so the patients don't get delays in their therapy. The next item was actually something that we enacted through the due to the COVID disaster state plan amendment that we submitted. And this is actually the reimbursement for administering healthcare administered drugs. Pharmacists for a long time have been able to administer flu shots. What we wanted to do through this disaster relief SPA was for drugs where it had to be administered by a healthcare professional, we wanted another avenue for patients to be able to receive those medications. Typically, what we were thinking about was the atypical antipsychotics, the long-acting ones, like Abilify Maintena and those types of products. When the patient was picking up the medication and then having to go into their prescriber's office, the clinic or whatnot to get this injected, we thought that there was likely going to be some loss to follow-up. We did hear anecdotal reports from the field that prescribers were starting to switch their patients over to oral therapy from their long-acting injectables. And we didn't want to remove these valuable tools away from prescribers and patients from being able to continue to use them. So as far as our rules go, we did put out a bulletin regarding this. I think it was about 2 months ago. And we do not allow reimbursement for administering a product that's typically self-administered. So I don't want to see in our claims data that the CPT code is being billed for the injection of insulin or something along those lines. These need to be truly those products that are healthcare administered drugs. You're going to utilize the CPT code that's on the screen, which is 96372. You are required to use the TT modifier in order to get reimbursed correctly as a pharmacist. Currently, we're reimbursing at a rate of $18.70. There is a limit of 1 unit per participant, per pharmacy, per day. And this is in line with how that CPT code is billed for anything else. 96372 is not an allowable CPT code for the administration of vaccines. There's actually a separate CPT code for the administration of a vaccine. You can continue to do that through Direct Care Pro or collect the dispensing fee as the administration fee on the point of sale claim whenever you bill it through your point of sale software. The billing is a little bit different for these. We're talking about CPT codes instead of NDCs, so the billing is done on a medical claim, not through the point of sale system. Some software vendors out there I've seen will take the CPT code and go ahead and convert it into a medical claim for you. I'm not sure how popular that is yet in Missouri, but I believe that service is available. One of the things that we wanted to avoid was having to have pharmacies and pharmacists enroll with the managed care companies for this. So all the billing is going to be done through our fee-for-service system for all participants, regardless of their managed care coverage. So most pharmacies at this point, it's been since October of 2009, haven't had to deal with managed care companies. And we wanted to make sure that that would continue to be the case. So even if a patient walks in with a managed care company, still go ahead and bill us through our EmoMed system or your medical billing software for the CPT code. And then lastly, the administering pharmacist must be a healthnet provider. This is one of those that we want to make sure that you are getting enrolled as a provider. We're one of the few states that already has this in place where pharmacists are providers, so please do take advantage of it. The link is here on this website. I believe there are groups out there that will help walk through this process with you, but we are working very rapidly at getting pharmacists and all providers through our enrollment process. Due to COVID, I think we actually increased our speed even a little bit more. I know in the past, this was a very difficult process to get through, but recently we're talking days, not months, in order to get through the provider enrollment process. All right, and next, third-party services for PA requests. healthnet does not accept PA requests from a third-party vendor. There are a number of companies out there that are marketing themselves as the preferred PA vendor for healthnet, and this is inaccurate. We've actually had conversations with them regarding taking that kind of information off of their website. What we expect is that the PA requests will come from the prescriber or their in-office representative, the pharmacy, or the patient. Requests from third parties typically will result in a delay in sending and receiving participant information, and we have noticed significant accuracy issues with the information that we receive. What do I mean by this? We definitely receive PA requests where it's the patient's first name and the doctor's last name. We receive requests where the data is not correct. It's obviously for a different patient. We receive requests where the requests are actually blank other than the requested drug. We have never preferred a third-party vendor, and we do not plan on doing that anytime soon. I actually wanted to save quite a bit of time for questions, as I typically get several of them. But the next couple of slides are just helpful links for you. So our clinical edits are always up to date and posted on our website. We try to put them in the classes that make the most sense, but sometimes due to the way the medications are classified by the manufacturer and the number of things that they can treat, it gets a little bit confusing. So if you do have questions on that, feel free to reach out to our pharmacy admin email at the bottom. We also have our frequently updated documents. That's where we're going to keep our diabetic supplies and other new drug edit related items. Our diabetic supplies at the beginning of the month went to a 1 of 1 preferred, and we also cover CGMs for type 1 diabetics now. The PDL searchable database is a great resource for people to keep on their phone or in their pharmacy. That will tell you under each class what our preferred product is and what our non-preferred product is. The one caveat to remember with our PDL searchable database is it is only for those products that are actually on our preferred drug list. If it's only a clinical edit, we do not keep those drugs in the searchable database at this time. I recommend that everyone sign up for our hot tips and bulletins. That's where we're going to find out about any COVID related items, any changes we're making, such as early refill, the bulletin that we put out regarding the diagnosis code and things like that. You can get an email dropped into your inbox as soon as we make those changes. Very, very helpful in terms of keeping you informed. The next page is going to be our calendar of events. So that's where we post all our public meetings. Our PA committee meetings are quarterly. Our DUR board meeting follows the month after that. And then we use the month in between to try to get prepared for the next round of edit changes. The PA committee, that link is going to take you to our proposed documents. That means our documents before they actually are approved. Really a great resource if you have questions or a class is coming up that you have a strong opinion or you notice something that you would like healthnet to change, we can take it into consideration. It's much easier for us to respond to comments and requested changes if we have them in advance of our PA committee. Otherwise, it might be a situation where we have to wait a year or more before we can make another change. Our provider education website is there. Right now, the big thing is the pharmacy billing of the medical claims. We have a step-by-step presentation available for you to walk through and find out exactly what we expect on how to bill the medical claim for the healthcare administered medication. And then lastly, I think everybody on this call knows this phone number, 800-392-8030 is our pharmacy help desk. When you call that number, please keep in mind that you can to listen to the IVR as it has changed recently. All right.
Okay, we're going to take some questions now. We have some that came in. We have some that came in that are unrelated to today's topic, so we're only going to answer ones related to today's topic. If you have a question unrelated, you can always send it to your inspector, or on the board's website, we have a couple new mechanisms there where you can send a question to the office or to an inspector, and you could send your questions in doing that way. So if you have a question, you can go to your toolbar and type it in and hit send, and we should get it. So I'll just read some of them off, and Josh can answer them. Let's see. For long-term care, can the nursing staff at the facility provide the diagnosis code to the pharmacy?
Yeah, and that what we're looking for is whether or not the diagnosis code is actually on the patient's chart. So that's what we're going to be comparing against. I think one of our concerns was, I know years ago when we had an edit in place for the SSRIs, a lot of people just assumed that it was for depression. So when they would call our help desk, they would say the SSRI is being used for depression, when it could be used for anxiety, it could be used for back pain as well. So there's a lot of other indications that these drugs could be used for. And what we're trying to do is ensure that the diagnosis code is accurate.
If we have access to Epic, the prescriber notes, I guess, in an EMR, are we able to take diagnosis codes from there and document that?
Yeah, so absolutely. Again, this goes back to the first question. As long as that diagnosis is documented in a chart or someplace where we have, where it can be verified that it actually came from the prescriber, that's what we're really looking for. Yes.
Now, follow up on the benzodiazepines. They're asking, what documentation would you need to collect from the prescriber on benzos or benzodiazepine opioid interactions besides previous med history?
Yeah, so this is actually something that we're definitely talking about right now, setting our policy. So what we want to avoid is starting a new patient on a chronic path of an opioid plus a benzodiazepine. So we're actually in quite a bit of discussions on what we would expect to see in that interaction. And if you do have additional input that you want to give us, feel free to reach out to the pharmacy admin email address, like we said, and we'll definitely chat a little bit more about it, because what we want to do is make sure that we're not interrupting therapy, but what we are doing is avoiding all the potentially dangerous interactions that we can.
Someone's asking, is testosterone injection reimbursable? I don't know if they're talking about the drug or the administration.
Yeah, so I would have to look specifically if that person could clarify the question, what they're looking for. Mo HealthNet, we are restricted by what is called a covered outpatient drug. So this might be a little bit more in the weeds than most people want to get into, but what the drug company has to do is actually sign a rebate agreement with the federal government. And once they do that, we do cover their drugs. If they do not sign a agreement with CMS for the federal rebate program, then we do not in general cover that drug. One of the examples is the AviQ product. They have decided to not sign a rebate agreement with the federal government, so we do not cover that medication. But yeah, if that person could clarify the question, I would love to answer it.
Is there an available list of drugs that would be covered for reimbursement under healthcare administered drugs?
So we don't keep a list like that. There's actually not an indicator on claims. What we would expect to see is that the patient, that you're actually looking at the package insert to make sure it's one. In general, the items that we're talking about, Depo, Provera would be a healthcare administered drug. Makina, as long as that one stays on the market, would be something that would be reimbursable. Products that wouldn't be reimbursable, the examples were things like insulin. That's definitely one of those products that we would expect to be self-administered. There are a number of self-administered pens that are coming out, which we would not expect to reimburse pharmacies for giving a patient a self-administered medication. We're going to try and be as lenient as possible as we can before we start doing any kind of audits, but I think as long as people are responsible and reasonable with what they're doing, we won't have any kind of issues.
You mentioned that pharmacists could bill for vaccines via DC Pro. They thought the functionality had been removed from the tool. Has it been re-implemented?
So as of right now, you can still do your immunizations through DC Pro. We actually do envision that we will remove that functionality from DC Pro. That will allow pharmacists to either bill through their point of sale system, where we would reimburse the ingredient and then the dispensing fee would be the administration fee, or you can go through Direct Care Pro or your medical billing software for ingredient plus administration. We will put out a bulletin when we remove the functionality out of DC Pro for billing of vaccines.
Can you clarify if a diagnosis code is provided on the pharmacy claim for a medication that normally requires a clinical edit for a diagnosis code, the claim will process without a call to the provider?
Yeah.
A call to provide the code, I guess, to you.
Yeah, so on that one, it actually kind of depends. So we'll go back to my example of Humira. If you enter in a diagnosis of depression for their Humira prescription, likely you're still going to have to make a phone call because that is not on our list of approvable diagnosis codes for Humira. So I'm not going to tell you that 100% of the time when you enter in a diagnosis code, you will not have to make a phone call. However, if it's in the case of a patient and they are getting their first prescription for Humira, they meet all the other criteria, and the only thing that's stopping them from getting the medication is a diagnosis of RA, then it would allow it to go through without a phone call. Another example that we have recently come across is for prescribers that are seeing patients for pain. We have a number of pain-related diagnosis codes in our opioid edits, and some of our prescribers actually are not billing us with these diagnosis codes. So unfortunately, we have to talk to the pharmacy and prescriber every couple of months to manually put in a prior authorization. With the diagnosis code being able to be entered in by the pharmacy, we expect that a lot of those calls will go away.
Someone's asking for more clarification on the copay waiver for patients that have Missouri Medicaid as a secondary plan.
So I think the question there is actually asking about the remaining copay. So if the remaining copay is that $2, $1, or 50 cents, then that is what we're talking about not being able to charge the patient, because that is what we have to do in order to be in compliance with the federal funding from the CMS, is we have to waive the copays for Mo HealthNet paid claims. MoRx is not technically in this realm. So when MoRx is the secondary payer for a patient and we cover that half of the copay, then we're not talking about waiving the other half of it.
Are pharmacists able to administer Depo-Provera or testosterone as it is controlled?
So if those have healthcare, on the package label, they say that they're to be healthcare administered, then we would expect to reimburse pharmacists for the administration of those products.
And I'll just say the board's rules wouldn't prohibit you from administering a controlled substance if you had the proper prescription for it. Someone's asking, what is the professional fee paid for a 30-day fill?
So currently our reimbursement methodology for the professional dispensing fee is posted in our regulation on our website. I will not tell you the exact amount on the phone because I'd hate to be off by a couple of pennies. But if you go to our website, you'll actually be able to see what our professional dispensing fee is.
Do you have a list of medications that require a diagnosis code?
We do not have a list of just the medications that require diagnosis codes. Each one within their clinical edit will actually specify if it requires a diagnosis or not. So while some medications are more highly diagnostic, for example, the TIMs I keep on coming back to with Humira have a number of diagnosis codes in them. Things like atenolol and the ACE inhibitors don't have any diagnosis code. So it truly is a case-by-case, edit-by-edit project.
Will there be a more specific claim rejection message put in place, especially regarding the need for a diagnosis code?
We are not at this time planning on putting in more specific claim rejection messaging in place for the diagnosis code. One thing that we will do is if the diagnosis code that is submitted is not a valid diagnosis code, we will reject those. But as long as it's a valid diagnosis code that's being put in or no diagnosis at all, you shouldn't see any different denial messages from healthnet.
If the pharmacy is in the hospital, can we review the patient's medical chart and get the ICD without calling the office?
Yeah, so again, this goes back to just making sure that you are getting the information from the patient chart or the prescriber in order to make sure that the diagnosis code is accurate.
Are you educating the physicians to place the diagnosis code on the prescriptions?
Yeah, so we actually had planned to do some outreach to prescribers. Unfortunately, due to COVID, most of those conferences are being canceled. But through our public meetings, as much as possible, we are attempting to educate providers about the diagnosis code.
How are questions being sent to providers about polypharmacy?
We fax those to the prescriber is typically how we will interact with the provider's office. Of course, the prescriber can also request that the help desk call them through cyber access. So we do that quite often. The faxes that we send will typically spell out exactly what we're looking for as far as what the patient's current regimen appears to be to us based on paid claims history. What we typically will ask is that the prescriber confirm that these truly are the medications the patient's on right now, and then asks what the diagnosis is associated with each of those products. And then if there are specific questions, for instance, we notice a low dose or a lab that is very, very low for valproate levels, then we'll ask about those as well. But typically via fax to the prescriber's office. That's why it's very important that we get the accurate information on how to contact these providers.
Is there a minimum benzodiazepine daily dose for being flagged long-term as monotherapy?
So we don't look for a minimum dose. If a patient was on 1 milligram of Xanax every single day for a year, we would still flag that as monotherapy for monotherapy long-term of alprazolam. But we would be looking for in monotherapy is really any other anxiety type related medication.
When billing vaccines, are you saying the administration fee needs to be added to the claim separately, or is the administration fee added automatically when we send the claim?
So for the billing of vaccines to healthnet, if you are using your point of sale software to submit this claim, which I'm assuming it is, that's what we typically see from pharmacies, the dispensing fee is actually the administration fee. So we automatically will put that on the claim when we send it back to the pharmacy. So the payment that we're receiving through point of sale is the ingredient, and then the same dispensing fee that you would get for any other medication, but it's actually the administration fee. Vaccines are actually not considered covered outpatient drugs under CMS, so we cannot pay a dispensing fee on them. That's why we say that that's an administration fee in the case of a vaccine.
How do we document telehealth and DC Pro claims?
Yeah, so actually it's a place of service indicator within the module. So when you're billing the claim on the billing screen, and it's been a few days since I actually pulled up one of these screens, you'll go in and select place of service telehealth. I believe it's O2, but you'll have to confirm whenever you're actually going into billing it.
Will special consideration be given for oncology patients regarding opioid benzo new starts?
Yeah, so oncology patients are already separated out for our opioid related items. The difficulty with us there again is identifying an oncology patient in real time. So if there's a diagnosis cancer related on the patient's profile, we can pretty easily identify a patient as having cancer, and they get a few different bypasses on our edits related to opioids. We don't yet have that logic built into the benzodiazepines, but I think that's great feedback for what we should probably do as we review our opioid and benzodiazepine policy.
So we have some follow-up on our original testosterone question. They want to know, is there a fee for giving the injection?
And I haven't looked at the testosterone package insert recently, but if it does say healthcare administered, then we would pay an administration fee for that one.
Okay, so we have a question on, is there a way to submit questions? They want to know if there's a way to see the questions that were answered today. The answer is no, we don't have a list. You can listen to the recording again. And then is there a way to submit questions afterwards? And Josh says you can submit them by email.
Yeah, we have our email listed again in that helpful link slide, mhd.pharmacyadmin@dss.mo.gov.
So we will post the recording. It can take up to 2 weeks before we get it online, and you can re-listen to the program if you need to hear one of the answers again. What are you doing to educate the physician on multi-use of atypical medications so the pharmacist is not educating them?
Yeah, so we actually have a program where we do outreach on a number of topics related to behavioral health specifically. So 6 times a year, when we notice that there is a prescribing pattern outside of normal, we'll actually take the patient's profile, we'll put what indicators we found are outside of the normal range, and we'll send that to the prescriber. So every year we reevaluate what those topics are and what we need to reach out to prescribers about. And I believe the multiple atypicals are on the list for us to educate prescribers again this year, as that tends to be an ongoing issue. We've been doing that project for a number of years, and it's not one of those that will likely go away anytime soon. We'll have to continue to do the outreach. There's a number of psychiatrists and pharmacists on that committee where we try to do the outreach as best we can.
Can we expect the waiver to require a patient to manually sign proof of delivery to continue with COVID?
Yeah, so I think the question here is healthnet allows the pharmacy or the delivery service to write COVID in the signature log right now. We're going to continue that for the duration of the public health emergency, which we are all finding out almost in real time via the news. We don't have a lot more insight into when it's going to be extended at the national level until everybody else does.
What kind of documentation should we make to waive copays? May our patients receive their meds delivered? Will there be guidance later on how to refund copays that have been taken?
Yeah, so on this one, we've actually had a number of hot tips, and I think the confusion lies in the way that copays are paid for medical services versus pharmacy services. So what happens on a medical claim is when the patient is charged a copay, the 50 cents to $2 is actually taken out of the payment that's given to the pharmacy or to the clinic. For pharmacy, the copay is an above and beyond payment that the pharmacy is taking on top of the dispensing fee. For instance, when you are filling a prescription for an atenolol prescription, if the patient was under the age of 18, you would be accepting payment for the ingredient, and then you would accept our dispensing fee. Our dispensing fee for that product, I believe, is in the $19 range. For an adult, and there's likely caveats to this, so this is an oversimplification, we would again pay you for the ingredient. We would pay you the same amount for the dispensing fee, but then you would go collect 50 cents, $1, or $2, depending on the cost of the medication from the patient. It is incredibly difficult for pharmacies to keep track of the co-payments based on the point of sale system connection to their actual cash registers. We do not expect pharmacies to go back and refund co-pays for things that occurred prior to us putting out the bulletin. What we do expect is going forward that no co-pays be charged to patients for healthnet claims. And we've actually heard of a number of pharmacies that are holding back prescriptions altogether until patients pay their copay, which has actually never been a rule. We've always said that, and part of the provider agreement is that you will accept the payment from healthnet for the medication as payment in full and dispense the medication to the patient if they cannot afford it. It does become a legal debt during non-COVID times, but you still have to give the patient to the medication to the patient.
This person's applying to be a provider. Do they need to have a provider number for every location or store that they work at?
Yeah, so I would work with provider enrollment to let them know which locations you're going to work at. That might be a question to follow up on and send to us separately so we can respond to that person directly. But in general, they would not require a new provider number for each location they're working at.
We noticed that the edit is back in place on albuterol inhalers. We were told we wouldn't have to switch back to preferred product if we had to switch them during non-preferred during the shortages.
Yeah, so when we actually looked at the albuterol inhalers, we did re-implement the edit. We noticed that very few actually submitted claims for those new preferred products. Typically, most patients actually stayed with the original preferred product across the entire healthnet population. We also talked to several wholesalers and pharmacies and made the decision to go back to just the two. For albuterol inhalers, I believe those have a compliance component built on them. So if a patient was on one of the non-preferred that then became preferred, that is now non-preferred again, as long as they're compliant, they could maintain and stay on those products. I know that was very confusing, but the specifics are actually on the edit if you'd like to review that.
Someone's asking where they can get more information on DC Pro.
Yeah, so you can reach out to the Cyber Access Help Desk in order to get more information on Direct Care Pro. Also, MPA does quite a bit of outreach on DC Pro as well. And I think we actually have a link on our website, but I do not have that handy right now.
Okay, well, we're going to have to end questions for today. We did not get to all of them, but we're going to move on here. The next webinars on August 19th, the board will be given its annual legislative update. There was some legislation this year that does affect the practice of pharmacy. We'll go over that. And then on September 17th, we're going to have a compliance and question and answer session with some of the inspectors that will try to answer questions from you. As I said, we do make recordings. It takes approximately, it could take up to 2 weeks before we get it posted on our website. And then we have all our previous webinars on our website. This year, I did a regulation update. Earlier in the year, we did 2 COVID-19 updates. And then in May, BNDD came and provided an update. Those recordings are all on our website. For continuing education, you must complete the post survey to get the credit. So at the end of the webinar, do not close your browser. This little window will come up telling you that the organizer has ended the webinar. Hit close on that window. Again, do not close your internet browser, and then a survey will pop up, answer the questions, and click submit. If you have any issues of not receiving the survey, we do get reports that it doesn't always work on tablets and phones. You can email us at compliance@pr.mo.gov, and we will email you the questions. You must get the answers back to us within 24 hours if you want to receive credit. We started something new with the last couple webinars. Instead of mailing certificates, we've been emailing them. It may take up to 30 days before you get that email, and you will get a certificate via email. So thank you today for attending our webinar, and thanks Josh for coming and answering all those questions for us. So I am now going to close the webinar.